Good morning, everyone, and welcome to Internal Medicine Grand Rounds. I'm Dr. Kim Williams, and it's my pleasure this morning to introduce our fantastic rheumatologist, Dr. David Armstrong, who will be speaking on systemic autoimmune rheumatic interstitial lung disease. Dr. Armstrong is originally from Pennsylvania, and he went to Albright College in Reading, Pennsylvania, and where he was magna cum laude. He then went to osteopathic medical school at Lake Erie College and then did his internal medicine and residency at David Eisenhower Army Medical Center in Fort Gordon, Georgia. He then transitioned to a rheumatology fellowship at Walter Reed Army Medical Center in Washington, D.C. And he is currently an assistant professor of internal medicine and doing rheumatology, primarily at the VA, although also at the University Hospital, as well as he is the chief of rheumatology at the Rex Robley VA for our soon-to-be growing rheumatology division. And with that, I'm going to turn it over to Dr. Armstrong and tell us about autoimmune rheumatic interstitial lung disease.
Thanks for that introduction, Dr. Williams. And yes, it's quite a mouthful as we add new terminology to lots of diseases. The new proper terminology in PC, rather than autoimmune interstitial lung disease, is systemic autoimmune rheumatic interstitial lung disease, which rolls right off the tongue. So, grateful to be here. And, we're going to learn a variety of topics, not just involving interstitial lung disease, because most of the diseases I deal with are systemic. So we'll have some cardiology and GI and dermatology and lots of other topics in there for all the subspecialists and internists out there. So, and I've been really excited about this lecture. I've been excited about a lot of lectures, but this one really excited to give because there's a lot of new information out there and wanted to get it out there and lots of up and coming great information from the rheumatology department, i.e. myself, until this June. Disclosures, I do own some stock in CRISPR technology. Dr. James Bradley had a few slides that are contributory to this presentation today. We did use some images, or I did use some images from the American College of Rheumatology as well. So what we're going to learn about today. So really what's on the horizon in rheumatology and at university here for you all to be aware of. We'll do some cases and deep thoughts, which I think will help with your thought process, and really how we think in rheumatology in approaching cases, especially complex cases. We'll go over some new terminology for you so you can all be politically correct in using terms that we deal with in the rheumatic realm. We'll go over a review of interstitial lung disease and then talk about specific diagnoses that fall within rheumatology, overlap with pulmonology for ILD. And then we'll highlight the new guidelines, really go over kind of treatment and screening guidelines so that you're aware of how to approach patients with ILD. So first off, I just wanted to send a big heartfelt thank you out to everybody out there. Really, it's a team effort, and I'm not sure how the university without having rheumatology has survived, which is great to be here. We're seeing some very difficult and complex cases and really making a significant difference in patients' lives, both in the inpatient and outpatient setting. We can't do that without you as my colleagues, subspecialists, the interns, residents, house staff, pharmacists, all the ancillary staff, nursing support. And I really wanted to say thank you because we've had some cases that, have come even from other academic medical institutions here, and we've made a big difference in those patients' lives, which is wonderful. So on the horizon, what's coming new? So I created the slides and finished the presentation before we actually moved. But yesterday we moved into the new outpatient center multi-specialty clinic. So same building, HCOC, one floor down, suite 550. And I got a lot of new friends there. So we got bone health, burn, inflammatory bowel disease, MS clinic, neuroimmunology, specialty injections. Phone and fax are still the same, so don't worry about that. Patients should be aware of the move, and we've moved to Cerner, so we're slowly addressing that. And then we're going to get a new chief. Dr. Sarakbi will be here in June, so it'll be nice to have a colleague and a boss and really cut down on the wait list and get your patients in quicker, get them assessed, and provide really a building department with a hope to build back the fellowship program here in rheumatology in the next few years. What else is new? So we've created a multidisciplinary interstitial lung disease review that's going to occur on the first Friday of each month at noon. We'll have pulmonology there, pathology, radiology, pharmacy, myself. So really doing the deep dive into addressing these cases, providing a good standard of care throughout the spectrum of the disease assessment and treatment. So before we get into cases and deep thoughts, I just wanted to present this to you and a couple thoughts as we look at cases and how we approach disease. So artificial intelligence, I'm sure you're aware, is coming. My big take on artificial intelligence is I think it's a good thing, but we already think like artificial intelligence. It's just driving that information out of our visits and assessment of labs, imaging studies, and pathology and otherwise to really come to a consensus of diagnosis. So how well is AI doing? So 5 variables. We take a simple diagnosis of gout. So pain, gout is the chief complaint, history of gout medications, any musculoskeletal pain, and gout in the problem list. And it has a 75% sensitivity for detection of a gout flare. Physicians didn't do that great, 50%. So really it's honing out those key features of chart assessment, patient assessment, history, to really come to a diagnosis. And this will come into play as we go through cases here. But I would encourage you to think like this. And really my example is, when I was a teenager, we went to one pediatrician. It's great. But I always wondered, when we were having our assessment, I'd come in with ear pain or something else. And he wouldn't say a word, quiet the whole time. Take a look at a few things, tell me this is what we're going to do and give me a prescription. I always thought he was thinking about going to the Jersey Shore or something else during our visit, but he was deeply involved in assessing everything that was being told to him. Comparatively, his son took over the practice and, needless to say, just didn't have the same attentive detail, really what AI is driving out of everything with our visits. And when I called in with 105 fever, misinterpreted as 100.5 fever and told to take ibuprofen regularly, wound up in renal failure. So really, I think this kind of highlights the example of intuitive listening to your patients and really, as you look at your practice and AI is being incorporated, pulling out the key clinical functions of listening, chart review, everything else that AI can provide, and making that part of your standard practice. So we'll get into cases and deep thoughts here. So as you all know, I love Oscar. So listen to your patient. He is telling you the diagnosis, or she. So I usually like to start with, have you ever had this patient? So it's a humdrum Tuesday morning, 9 a.m. at the VA. So I have a patient come in for arthritis and dermatology complaints. So rash, it's a hyperkeratotic rash on the ear and swelling at the MCP joints. Now, my patient gave me full disclosure to tell all about his case because he wanted the word out there for this unique diagnosis so it's not missed. So as we're doing our assessment, I'm thinking, oh, this may be psoriatic arthritis. There's a rash on the ear, swelling at the MCPs. And I asked him, hey, what's been going on? Oh, well, his wife chimes in. She tells me 3 key clinical things where I realize that my humdrum day is turned upended. She says, did you tell him about your fevers? So that has my attention. Did you mention the double pneumonia? Now, I will tell you, anything that's double, bilateral, refractory should always get your attention when those words are mentioned because it's never anything that's predisposed to be. It's always something else. And then did you mention that you have been short of breath since being off of steroids? So immediately in my hierarchy, I'm thinking that this may be an antisynthetase syndrome based on the symptoms with ILD. So other key clinical features that we later determined as I took a closer look with imaging and also patient assessment, there's some hyperkeratotic plaques over they were over the PIP and the MCP joints as a representative patient. Pictures, abnormal nail fold capillaries, which you look very close. There's some hyperemia and also you can see some hemorrhaging to the nails. The rash not only involves some hyperkeratosis on the ears, there were some violaceous patterns to the face, and a representative example of chest X-ray and CT scan with interstitial lung changes. So I put this into my hierarchy or diagnosis category of antisynthetase syndrome, However, I was completely wrong, and we'll talk about where this case goes later in the discussion. So I myself have changed how I approach ILD. A couple years ago, when anybody with ILD came in, I wanted immediately a biopsy to really determine the cause of the ILD. And we'll talk about how that may or may not be right and how really assessment of these patients has changed, with multidisciplinary approach to interstitial lung disease. So I'm going to highlight another couple cases that we had here, which would seem very classic for what you would think would be granulomatous polyangiitis. Cavitary lung nodules, ANCA positivity, double-stranded DNA positive, which is an outlier, hematuria and proteinuria, elevated creatinine, and elevated acute phase reactants. And if you look to the left, the image, you'll see some cavitary lung nodules, right? So this would scream that it might be GPA. There's some outliers. When we talk about AI and assessing these cases, the big outliers with these cases, they were all hyponatremia. They all had hyponatremia. Their kidney function started to get better. And then ironically, as we would not think with lupus and other autoimmune diseases, the ANA is negative, but the extractable nuclear antigens are positive. So really, two of these cases wound up being lung cancer. One had more spiculated lesions, and the other had cavitary lesions similar, so we had squamous and adenocarcinoma. But the hyponatremia is a big outlier. It's suggesting SIADH, improving renal function, and they're really discordant labs. Remember, cancer can produce a lot of autoimmune positivity with labs, antiphospholipids, and otherwise. So we'll get into some terminology just so we're all speaking the same language. So when we talk about systemic autoimmune rheumatic disease, that's mostly everything I deal with. Also, we can term this autoimmune. So when pulmonology talks about autoimmune ILD, they're saying the same thing, or collagen vascular disease ILD. Those would be all the same terms. We've really moved from describing Sjogren's as a syndrome to Sjogren's disease now. So that's a new change. And then really scleroderma, which is really an antiquated term, we now refer to as systemic sclerosis, because really it's not just a skin involvement with this condition, it's a systemic disease affecting multi-organs. So Dr. Bradley provided this slide, which I think is excellent. This is the large interstitial lung disease tree. And really what we're going to focus on today, rheumatoid arthritis, myositis, systemic sclerosis, and Sjogren's disease. But there's a lot else out there that causes it, and we'll add a couple branches to the tree with regards to medication that we use commonly that can also induce ILD. So when everybody looks at this slide, myself included, I really didn't have a great approach. I know what honeycombing looks like, which is going to be your usual interstitial pneumonia to the top left, NSIP, which is more kind of ground glass, but there is some fibrosis associated with it. But really remembering these terms. So the easiest way I've found to remember it is to associate it with something that I know. So usual interstitial pneumonia. So the way I remember that, it's like eating Honey Nut Cheerios every day for breakfast. It's the same old usual thing, with the honey component that reminds me of the honeycomb fibrosis pattern. So the nonspecific interstitial pneumonia, the way I remember that, it's a little bit nonspecific when you're drinking bourbon out of a ground glass and you're not really sure, is it fibrotic or inflammatory? That's the way I put that into my memory to remember it. So the lymphocytic interstitial pneumonia, really, you'll see kind of the arrows pointing to the thin-lipped cystic production of fibrosis there. And really the way I remember that is kind of thin-lipped fish lips. So that reminds me of the LIP pneumonia. And then really, I think most folks kind of understand what organizing pneumonia looks like to the bottom right, where it almost looks like a pneumonia consolidation. So that one is fairly easy to remember. But we'll talk about kind of all these patterns here today and as they relate to autoimmune lung disease. So how are we detecting this? All right. So really, when we talk about the conditions that are associated with interstitial lung disease, in my realm, it's going to be rheumatoid arthritis, Sjogren's disease, myositis, and systemic sclerosis. So if we're concerned about it, they probably should be screened at baseline with a pulmonary function test, and at the bare minimum, a chest X-ray, but preferably a CT of the chest, and high resolution. When we look at once they're diagnosed, it's great. The American College of Rheumatology came out with screening parameters every 3 to 6 months for most patients, and then at least every year afterwards, desaturation testing, and a really high resolution CT as needed, although typically this is done with PFTs on an interval basis for assessment to response to treatment. So really, when we look at diagnosis, right, we've created kind of a lab panel for both the VA and the university because the testing, secondary testing and send-outs are separate. So a lot of the secondary testing from university is sent to Quest compared to LabCorp at the VA. So pulmonology has a list of additional testing and screening parameters, laboratory analysis for rheumatic ILD. But it's suspicion. If you see one of these patients, whether it's in any clinic, and they're complaining of shortness of breath, or you have concerns, or they haven't seen a rheumatologist or a pulmonary doctor with these diagnoses, they probably should be screened as part of their annual physical exam or assessment. So we're going to do that with a high resolution CT, as we talked about, and a pulmonary function test. You know, if there's any concern based on those, that's really where they need to be seen by rheumatology and also pulmonology, probably a little bit sooner than me, and we'll work on that wait list for you. And then we add, you know, other history and physical exam, and we'll talk about that. Serologic analysis, which is a little bit different at the VA compared to here. Bronchial alveolar lavage, sometimes to rule out infection or other causes. And also histopathology, which sometimes is important, and we'll talk about when we need to get biopsies of the lungs. It's not every patient with ILD. And really what we're moving towards, right? And this is what Dr. Bradley, you know, is very excited about is, you know, we're building the multidisciplinary approach, which is important. But really what we want to get to is, you know, we have a totally integrated system for assessment of ILD. And one of the fellows in pulmonology said, geez, I think we're seeing ILD all over the place. And why is that? And I think a lot of it may be due to, you know, really changing parameters for history of smoking. You know, now we're getting a lot of CT scans and assessment for lung cancer, which we didn't, you know, 20 years ago. Now we're seeing a lot more ILD, which may be subclinical, but getting these folks in very early, you know, is great. And I would say comparatively to folks with rheumatoid arthritis, we're not seeing people come in wheelchairs anymore. They're coming in with mild joint inflammation, and we're able to prevent deformities like we'll see later on in slides. Same thing with ILD, right? When I started fellowship, you know, folks with ILD would come in on 4 or 5 liters of oxygen. We're not seeing that anymore. And I think that that's great with the multidisciplinary approach is really we're catching disease early. And I think some of that may be, you know, lung cancer screening parameters, which I think are wonderful, and really preventing folks from needing lung transplant, being on chronic oxygen, and other things that, you know, unfortunately we're playing salvage work to help save these people's lives. So really when we look at, you know, why are we not doing biopsy? It's a pretty good 2% 30-day mortality, right? So we really need to triage patients and who needs a biopsy and who doesn't. But, you know, what I would tell you, and similar to the 2 cases we discussed earlier, there's outliers, right? If we're suspicious of cancer, they need a biopsy to rule this out. And that's very important because, you know, I would say a majority of our patients in the area smoke and really a risk factor for developing RA. And we're really trying to make a dent with that with the multidisciplinary clinic and having our pharmacist assist with smoking cessation, which is wonderful. But, you know, we see a lot of smokers and a lot of other things that can cause lung cancer, patients on immunosuppressant therapy otherwise. So biopsy does play a role, but not every patient with ILD. So really when we look at, you know, breaking down, okay, we have these abnormal PFTs, you know, the DLCO is decreased, the high-res CT is abnormal. You know, really the decision point then is this looking more fibrotic or more inflammatory? Now, classically, UIP, which is higher in prevalence in RA, very inflammatory. So that's when we're looking at antifibrotic therapy. Nonspecific interstitial pneumonia, really, you know, kind of overlap between, you know, some fibrosis, perhaps some inflammatory component. And then really, you know, ground glass opacities and consolidation really fall more into the inflammatory realm. So we'll start off with kind of approaching each one of these diseases individually. So here's your classic picture of rheumatoid arthritis with inflammation, ulnar drift to the knuckles, and then also MCP predominant involvement with some nodulosis that you can see particularly on the right hand, or the left image, but at the right hand, the PIP joint, you can see some nodulosis forming there. So this may be actually, the initial presentation in patients with rheumatoid arthritis, up to 20%. So they might walk in short of breath, not able to breathe, and you're wondering, do they have COPD from smoking? Could it be something else? And really, you're doing that assessment, and lo and behold, you find ILD. And really, it occurs pretty quickly. So a lot of patients, and this is kudos to the American College of Rheumatology screening guidelines, is, this can occur within the first 5 years of diagnosis. So it can happen fairly quickly. And typical presentation that you're going to hear complaints about is dyspnea and cough, which, we see a lot of that in the clinic. So what are the risk factors, for ILD and rheumatoid arthritis patients? Well, older males, okay. Seropositive disease, which suggests, particularly rheumatoid factor, they've had ongoing inflammation for 5 years. So chances are we're in that window of, developing ILD. Nodulosis, HLA testing is abnormal with the DRB1. Smoking, right? Everything is higher in smoking, but it's going to accentuate damage to the lungs. And, really kind of, one of the most important things to have patients do is quit smoking if they have ILD. You're going to have a lower FVC, especially if there's fibrosis, and then a low DLCO, suggesting not good oxygen exchange in the lungs. And really, most of these patients are going to have more of a fibrotic pattern. They're going to have the usual interstitial pneumonia pattern to the lungs. And unfortunately, it's taken a while for folks to get in, 24 months to get in with a pulmonologist. So those folks out in the front lines in the clinics, be aware, be on the lookout, especially with other risk factors for ILD. But in our realm, if they have a known diagnosis, haven't been in with a rheumatologist, haven't seen a lung doctor, still smoking, really need to get them in and get them assessed with PFTs and high-res CT. So when we look at the breakdown, right, we talked about UIP being, the highest prevalence in RA, it's about 56%. NSIP, which kind of has some overlap of fibrosis and inflammation, about 33%, and then organizing pneumonia, which we now know is more inflammatory, about 11%. So really, this is where the big decision point, is taking place with myself and, the ILD clinic and pulmonologist is this more inflammatory? Is this more fibrotic? And what's our pathway that we're going to go down? And we'll talk about that in the treatment guidelines a little bit later on. So guess what? Our medications, they have some risk too. So lo and behold, this is a great cohort study, 30,000 patients. So that's pretty good, darn good when you're looking at cohort studies. So 1, 5, and 10-year follow-up, so long-term data. And we've done a 180. We used to think methotrexate and ILD, total contraindication, makes lung disease worse. Well, guess what? It doesn't. So, and this is what big data does. It really changes our mindset. And, when I did fellowship, if someone had ILD with RA, methotrexate immediately contraindicated. Well, that's not the case anymore. It may actually be helpful and beneficial long-term in preventing inflammation. One of our other medications, which I used to think was fairly good, especially folks with ILD, perhaps chronic infections, sulfasalazine, actually turns out it's not very good for ILD. It actually increases risk. So we're doing a 180 on sulfasalazine. Now, leflunomide, we've always thought that might be safe, which it is, that was proven. But when you start it, or you see somebody back that I've started on leflunomide and they're saying, hey, I'm short of breath, I can't breathe well, it can cause an acute interstitial pneumonitis, and usually within the first 3 months. Leflunomide has a very long half-life, so we do have a washout protocol with cholestyramine to get rid of it out of the system. We had to do that this year already for someone who got leflunomide and developed Stevens-Johnson syndrome. It works. It gets rid of the medication. It works very quickly. But I've had this happen, and until I was preparing for this lecture, we stop the medication when someone has, a side effect, but got acutely short of breath with, guess what? Sulfasalazine followed by leflunomide. So I doubled down on providing 2 medications that both provided lung toxicity in a patient with RA. So I don't want you to have the same pitfalls as me, but be aware, if you see these patients on those, whether they're used for other disease processes, ILD or inflammatory bowel disease, pardon me, or otherwise like the sulfasalazine, they can cause pulmonary toxicity. TNF inhibitors, which we use a lot of these, whether it's adalimumab or etanercept or infliximab, it kind of 50-50 split with regards to risk for ILD. So what's the co-founder here, right? So not all stuff in the lungs is ILD or cancer. So lo and behold, patients with long-standing rheumatoid arthritis and seropositivity also get nodules. We see that more frequently in smokers as well. So really, it's important, not all these are cancers, but just want to let when we look at the lung nodule clinics, what they're looking for. So really, these have distinctive findings, both on imaging as well as advanced imaging. So really, you'll see them more towards the periphery, which the circles demonstrate. They're kind of smooth. There's usually multiple, 4 or more of the nodules. They usually contact the pleura, and there's some rinds of soft tissue underneath. And they have a different low metabolism uptake and no draining lymph nodes on PET scan. So they look different. They're not spiculated, they're not large, not solitary. But you're going to see a lot of patients with long-standing RA who smoke too. So, this is really what's being done in the lung nodule clinic as they're looking at these with fine detail. But just so that you're aware, especially if you get the CT scan and it mentions multiple nodules, when you're looking at your own images, you can somewhat reassure the patient, while they're waiting to get in with the pulmonary nodule clinic, that these may not be cancerous and would be more typical of a rheumatoid nodule. All right, the bane of my existence, which is systemic sclerosis, our most difficult disease to treat. So really, when we're looking at these classic images here, you're going to see a couple things. So number one, I encourage you to always look for, abnormal nail fold capillaries as you're shaking your patient's hand, or look at them sitting in the chair. And we can see some of that telangiectasia as well as hemorrhaging if you look very closely to that left index finger. The other thing we're seeing is some calcinosis cutis there to the knuckle. You can see the calcium deposits below the skin. And of course, obvious findings would be the sclerodactyly or thinning or tapering of the distal phalange and the skin hardening with the shiny appearance of the skin. All right, so how are we doing on scleroderma, right? Or systemic sclerosis will be proper about terminology. Well, guess what? We're doing real good with renal crisis. And that I think that speaks kudos to recognition. We'll talk about kind of big risk factors with preventing that. But really, since the 70s, we're not seeing renal crisis anymore. It's on boards, you read about it, but we don't see it, right? And really that's using ACE inhibitors at key timing in diagnosis of renal crisis. Of course, all the residents always ask me, well, guess what, Dave? What if we used, an ACE inhibitor before patients got renal crisis? What would it do? Well, the data is out there. Large cohort, 20,000 patients from Europe. Using an ACE inhibitor without renal crisis increases the risk of renal crisis and potential death by about 2.5-fold. The other big risk factor is steroids of any form or fashion. So steroids are the devil for systemic sclerosis. They are going to induce renal crisis. So be very cautious, not saying that you can't use steroids, but use them with tongue in cheek with systemic sclerosis, because chances are that may be the risk factor that tips the scales in causing renal crisis. So where are we not doing well, right? Heart and lung disease, right? These have, it's almost like whack-a-mole. We take care of one disease process, another one pops up. So really the big thing with systemic sclerosis, which is a recurring theme, is the 30% rule. 30% of folks are going to have heart involvement, 30% are going to have, 30% will have heart and lung involvement, 30% will have pulmonary hypertension, and 30% will have pulmonary fibrosis or ILD. And guess what? The treatments that we use for advanced treatment, 30% mortality. So it's a very difficult disease to treat. But we have made a big dent in renal disease. So, we talk about the antibodies with that. So disease association. So we like to think that diffuse disease defined by, skin hardening proximal to the antecubital fossa is more diffuse disease. And we see more pulmonary disease with that. That's what they teach you on boards and everything else. Now we remember that. We like to refer to SCL70 on boards and otherwise as a topoisomerase antibody. Comparatively, centromere is more limited disease, so distal to the antecubital fossa with skin hardening and more associated with pulmonary hypertension. And anti-RNA polymerase 3, more associated with the renal crisis. So how does that really pan out, right? So I highlighted this for you. So just be aware, the systemic sclerosis is systemic sclerosis. The antibodies have some meaning, but really when we look at this large cohort of 20,000 patients, right, The cardiac involvement, pretty similar between diffuse and limited, defined by antibodies and the skin hardening. Little bit of difference that's a little bit more statistically, significant with pulmonary fibrosis, although plenty of folks with limited disease getting pulmonary fibrosis. And then really, pretty equal involvement of pulmonary hypertension across the board with both limited and diffuse. So remember the differences, but really you want to screen for all these disease processes regardless of antibody positivity. So why is systemic sclerosis so bad, right? So I've done a lot of deep thought about this and why our medications, really only stabilize disease with the exception of captopril for renal crisis. We're just not really treating these folks and preventing things from getting worse. Well, it's really kind of three things. There's endothelial injury, activation of the immune system, and then also fibroblasts and fibrosis, right? So really, I refer to this as a microvascular inflammatory fibrotic disease. Everything is hitting it. And that's why when we use antifibrotics or we use anti-inflammatory medications or DMARDs or biologics, really we're just stabilizing one portion of this three-pronged attack. And so I think we will move probably in the future towards more polypharmacy, and multidisciplinary treatment really to, prevent that 30% mortality across the board for patients, which is devastating. So when we look at the ILD, which I know is the main focus of the lecture here, and we kind of sidetracked, NSIP, which is kind of overlap of fibrosis and inflammation, really is the predominant pattern. And you're seeing some of the ground glass appearance and some of the traction fibrosis there on a classic CT image. So it was interesting to me, right? We have a lot of dysphagia and GERD with patients with systemic sclerosis. What differences do proton pump inhibitors make? Well, a great study out there. Really, they're improving the survival rate, with regards to ILD. They're delaying, progression because they're really preventing acid from refluxing in the lungs and accentuating any inflammation or fibrosis that's there. So, realistically, without a contraindication, I know it seems hard to believe, but you're probably saving someone's life by starting a PPI if they have systemic sclerosis. So, before myself, and doing this lecture, I would say, oh, if you have GERD, we'll start a PPI. But really, this study was eye-opening with regards to, preventative risk and really keeping folks out of harm's way with keeping acid out of the lungs. And this was across the board, limited diffuse, patients with systemic sclerosis. So if there's no contraindication, really, I would highly recommend, as one of the first line therapies for ILD is really starting a PPI. So it's great news on that front with simple things that we can do to prevent bad disease. So we'll talk kind of briefly about mixed connective tissue disease. So this is kind of, I like to refer to it as a mixed bag of tricks. We have a little bit of lupus, a little bit of systemic sclerosis, a little bit of rheumatoid arthritis. Really, maybe some skin hardening, photosensitive rashes, joint inflammation, perhaps some interstitial lung disease, maybe some kidney involvement. A lot of the mixed connective tissue disease, though, I find it really isn't that severe. It has some overlap, but generally responds to lower end treatment with severity and suppressing the immune system. Again, associated with the RNP antibody. And the reports, and data out there suggest about 50% of these folks will have ILD. I honestly don't see this rate. Really the ILD that I'm seeing with mixed connective tissue disease, probably in the realm of 5% or less of patients. But it's reported, I'm just not seeing that, and that may be the cohort of patients that I see in my clinic. And again, the pattern inflammation, fairly comparable to systemic sclerosis. So if you pick one of the three, I would say that a lot of times mixed connective tissue disease, will kind of follow patterns more of systemic sclerosis. Let's talk about myositis. So kind of classic features here that you're seeing, the mechanic's hands with hyperkeratosis and eczematous changes to the images on the left. And then on the right, you're seeing a heliotrope rash with the purplish or violaceous patches around the eyes. And this patient's also going to have muscle weakness. And again, if you're looking real close, which I always am, you're going to see some abnormal nail fold capillaries and hemorrhage if you're looking very close. So lots of antibodies out there and lots of different disease prognoses. So really the big theory that I would say to remember when you're looking at, someone with muscle weakness, again, is antisynthetase syndrome associated with the Jo-1 antibody. the SRP, which has a very bad prognosis and really less rashes and more heart involvement, and then the Me2, which is a dermatomyositis, which has a fairly good prognosis. Although I will tell you that Me2 patients are very sick and they're getting very potent treatment. So even being on the milder spectrum, it's pretty severe disease. So this is the panel from, this one's from LabCorp. The other panel of testing, when you're looking at send-outs from Quest, it doesn't include the HMG-CR antibody. So that's the one that's associated with statin-induced myositis and myopathy. So just be aware, when you're sending out the panels, when you're using a secondary source and send out, it may not have all the labs that you want, but both panels are fairly comparable. I've looked at these, so whether we're practicing at the VA or practicing at university, just be aware of the send out. The one big difference would be the Quest panel that's sent out here does not include the HMG antibody. The big three to remember from that. So the MDA5. So that's what our patient that we initially discussed with, the fevers, the double pneumonia, everything else went up having. And it's a very severe, rapidly progressive ILD. And we'll talk about that in a little bit more detail. But that one should highlight your immediate attention. And again, when we're looking at myositis, make sure if they're on a statin, that may be contributing and may cause an inflammatory myositis. And then the CN1A antibody. So that one really is associated with the inclusion body, which is refractory to all treatment. We try steroids and other things, they just don't work very well. But the good news is not a lot of associated ILD with that diagnosis. So when we look at myositis pulmonary presentations, we have a couple presentations, right? So they can kind of hemorrhage and bleed into the lungs, which is not good. We see that with antisynthetase syndrome. They can have a slowly progressive ILD, so they're not getting better. They can aspirate, so similar to our systemic sclerosis patients, aspiration, any acid in the lungs is not doing them any favors, so they may have asymptomatic progression with fibrosis. So the good news about myositis, with the exception of the MDA5, is it melts away with Rituxan and steroids. So similar to vasculitis, we get them on good therapy, and they will get better. The exception would be inclusion body myositis, which really is refractory to most treatments. So the MDA5, right? So the anti-melanoma differentiation associated gene, so there's another mouthful for you, is rapidly progressive. So this, when I initially saw the patient that we talked about earlier, started high-dose steroids, started rituximab, I've seen plenty of antisynthetase. I'm like, you're going to do fine. And that was not the case. The ILD was rapidly progressive, and despite Cytoxan therapy, wound up with a lung transplant very quickly, and is actually currently doing very well. So the other thing with the MDA5 is there is an association with CMV, and we'll talk about that. It may be associated with the pathogenesis and, of course, worsen prognosis, because if we're doing lung transplant and Cytoxan, CMV is obviously not going to get better whatsoever. All right, we'll move on to Sjogren's here, and then we'll get to the guidelines, kind of talk about what to do once we identify disease. So I think one of my patients put his summary of Sjogren's disease the best I've ever heard it. He says, it's like you have the flu and you're trapped in the desert. And that's really how patients feel. But with regards to Sjogren's, it really kind of stems from a polyclonal gammopathy. So, it throws off a lot of antibodies and makes people feel not well, but it doesn't really do a lot of damage compared to systemic sclerosis with multi-organs or rheumatoid arthritis, particularly with the joints, but sometimes the lungs. It makes people feel not well with a lot of, subclinical disease. It's very annoying. So I would agree with him, in stating it's like having the flu and trapped in the desert. And we do our best, but, a lot of times, really the symptoms, are refractory to a lot of treatments with the immune system and really don't cause a lot of destructive damage, but very irritating to patients because they just don't feel well. So they say about 50% of folks with Sjogren's disease have a cough, and I would say this is pretty accurate. We see a lot of folks, whether it's due to the dryness or some component of what almost appears to be asthma. That methacholine challenge these folks, and guess what? They have reactive airway disease. And then lo and behold, right, we're using medications that mimic acetylcholine, like sialagogues, that you would think would make them worse, but they do stimulate salivation and moisture, and they work pretty well. But we do caution folks that if they do make them short of breath, that may be some of this asthma-like component that we see with Sjogren's disease. So really breakdown, kind of falling into the same kind of pattern of systemic sclerosis and mixed connective tissue disease, a lot of non-specific interstitial pneumonia, about 50%, and then some breakdown of fibrotic and organized pneumonia. When you read textbooks and on boards, the lymphocytic interstitial pneumonia, remember the kind of thin-lipped cystic structures that we see, classically linked with Sjogren's, and that's always a board question. But, really only see it maybe, somewhere between 5 and 10% of folks with Sjogren's disease. And then really pathogenesis, when we look at Sjogren's, it's kind of the opposite of HIV. HIV, you're seeing low CD4 counts. The opposite is more kind of increased CD4 and deposition from CD4 positivity. And that's what we find in the submucosa, on lung biopsy in patients with Sjogren's. So we'll get down to the nuts and bolts of treatment guidelines, which is really where this lecture is headed. But if there's a lot of drugs, as Ozer would say, none are sufficient. But I will give you some that seem to work a little bit better than others based on the guidelines that we have. So we're looking at systemic sclerosis, right? We talked about that three-prong attack, lots of fibrosis, lots of inflammation, endothelial damage. It's doing a lot of damage from a lot of different ways. So, really, I find, and I'm finding that really more kind of lung stability with tocilizumab. So that's IL-6 inhibitor. We'll talk about the data for Cellcept and Cytoxan, which is a little bit mixed. But this is what I'm starting first line. Although we have other choices. Can we use mycophenolate, rituximab? Sure. Can we add on cyclophosphamide and antifibrotic, azathioprine? Sure. But the one thing I'll tell you, and we talked about it earlier, right? Unless you have a good indication for using corticosteroids, do not use them. You will induce renal crisis. It will happen. But I think, realistically, because antifibrotics are restricted to pulmonology and I can't prescribe them, I'm usually starting an anti-inflammatory with a biologic therapy and then referring them to pulmonology for antifibrotic care as part of the spectrum of their disease process. When we look at myositis, I know we talked about rituximab being great for anti-synthetase and most myositis patients. It really is. They've done some good study recently too, where they're talking about not only heart, but lung involvement, right? We have patients with elevated CK, they're short of breath, they're weak. You can't really tell what's going on in the heart. So really they're pushing for early echocardiogram in patients with myositis, looking for cardiac muscle involvement and getting folks on early treatment with IVIG, which is really making a difference. And, one of the patients with the Me2, the good prognostic antibody, developed a lot of heart failure after we treated with Rituxan and IVIG and plasma exchange. And I wonder, was there a lot of cardiac involvement and should I have continued IVIG protocol? But something to look out for too, when you have these consults or patients are admitted, with myositis, is also look, not only for the lung disease, but also for cardiac involvement. With mixed connective tissue disease, I just seem to find that it's a little bit milder with the organ involvement. And, really my standard would be to stick with mycophenolate for first-line treatment for that, although we have lots of other options. With all these, other than systemic sclerosis, short-term glucocorticoids to determine response, determine whether or not there's more fibrosis or more inflammatory component, perfectly fine. With rheumatoid arthritis, I typically stick with rituximab. I find that works fairly well for the interstitial lung disease and controlling the joints. And with Sjogren's, because of the polyclonal gammopathy and kind of subclinical disease, I also stick with mycophenolate there. But lots of options from the American College of Rheumatology for first line. Those would be my highlights and what I typically, use. But there's lots of other comorbidities and other reasons to pick different therapies. So lots of treatments, but that would be my consensus of how I approach initially ILD with rheumatic disease. So I know I told you we talk about systemic sclerosis and treatment. So our most potent systemic therapy, cyclophosphamide, right? So you'd think, right, this is autoimmune disease, it will be soul crushed if we use Cytoxan. Well, the evidence just said it doesn't do much for the lungs. In fact, they actually get worse than doing nothing at 2 years. So we had that data, kind of put Cytoxan on the back shelf. So then somebody said, all right, well, Cytoxan is pretty potent, causes issues, doesn't really long-term prevent, worsening lung disease, may actually make patients worse and make them sicker. What about, mycophenolate? Kind of works like cyclophosphamide light, so it's not quite as potent, less dropout from side effects and illness. What's the comparison? They say it works okay. If you look at the two lines, cyclophosphamide, which we defined as a treatment failure, mycophenolate doesn't work quite as well, although there may be a little bit of improvement in FVC long-term. So I will give you, I don't know on mycophenolate and utilization in ILD associated with systemic sclerosis. So why I think tocilizumab may be better, you look at stability. This is the same time course, 2 years, and looking at stability of FVC, pretty stable and seems to stay better than placebo. So I'm not sure, seems to look better, but again, we're limited to these 2-year studies where I can't tell you much beyond that, but I think it does work a little bit better. It does keep stable lung function without decline, which again, I think we're doing a little bit of salvage work with ILD and systemic sclerosis. We're not making people better and getting rid of the fibrosis and inflammation, but we're keeping them off oxygen, keeping them from having to get a lung transplant, which is great. So what do we do if that fails, right? What do we do if medications aren't working, right? So they came out with great guidelines that say what to do next, which is awesome. So with systemic sclerosis, again, with all these patients, if they're not doing well on therapy and they're getting sicker and they're requiring more oxygen, we're going to consider a referral for lung transplant. That's across the board. There's been some very good evidence that everything, whether it's, heart involvement, skin involvement, lung involvement, is cured with stem cell transplant at a center of excellence. The trouble is it falls in that 30% rule. There's a 30% mortality. So you've got a 30% mortality risk if you don't do anything and hope for the best, and a 30% mortality if we're even doing the most aggressive things. So, for second-line treatment for systemic sclerosis, beyond, biologic therapy and beyond an antifibrotic, really that's when you're going to start considering desperate measures. If they have heart and lung involvement, heart-lung transplant, those are pretty risky business. So, that's really where you may want to consider stem cell transplant. I've never found that patient where we're timing it right, where they're not too sick, but sick enough to get that done, but keep that in your armamentarium for something other than lung transplant, especially if there's heart involvement as well. For myositis, we talked about the IVIG. I would say that's probably a good second-line agent if rituximab does not work. And we'll talk about the MDA5 a little bit separately because that's a different treatment protocol. Mixed connective tissue disease, like I said, a little bit milder than systemic sclerosis, but kind of falls in that pattern. So realistically, I would consider tocilizumab, the IL-6 inhibitor we use for systemic sclerosis, really as a second-line agent. With rheumatoid arthritis, I would consider tocilizumab as well, although we have other options. And then with Sjogren's, probably rituximab as a good second-line agent if mycophenolate has failed. And we have some evidence for what we refer to as type 2 Sjogren's disease. In other words, low complement levels, more severe manifestations, whether they're neurologic or vascular in nature, that we do want to consider that. And of course, we talked about no steroids for systemic sclerosis and then referral for lung transplant with progressive disease. So rapidly progressive disease. So these are the folks that just, it's taking off with the lung fibrosis and inflammation. So MDA5 would really fit this pattern. So there's a lot we can do, right? And that's a big differentiating point from the American College of Rheumatology. Is this MDA5 that gets your full attention, right? So we're doing the steroids. We're doing 2 additional therapies, whether it's rituximab, cyclophosphamide, IVIG, mycophenolate, calcineurin inhibitor, or JAK inhibitor. And they have some evidence to suggest JAK inhibitors, the tofacitinib and otherwise may provide some benefit, although, I would triage these to kind of lower immunosuppressant benefit, but they do have some evidence to suggest that. And really consider early lung transplant. So, really, this is the last thing you want to think about is, hey, we have lots of choices. What are we going to do? And so, great Japanese cohort study that looked at, protocol-driven treatment, right? And that's what I like. You don't want to have to, when things are going bad very quickly, do a lot of guesswork of what to do and calling around and seeing what's safe. So, they did a great protocol. It involves high-dose steroids that are tapered, IV cyclophosphamide protocol, and concomitant tacrolimus. So, and it had very good success rate. So low mortality, good success rate, avoiding lung transplant. They also recommended, similarly, if the patients are going oxygen or their lung disease is still progressing to the protocol, to consider adding IVIG. You can do plasmapheresis as well as an alternative to IVIG. The other thing, right, we talked about that CMV association, is adding valacyclovir or acyclovir at the onset of diagnosis, right? They may be heading towards lung transplant, probably should add it. We have had some difficulties at the VA, in particular getting CMV testing with bronchoscopy. So if you don't know or can't get the data for CMV, this is one case where I would say probably should add prophylactic therapy, and then they should be on, pneumocystis pneumonia prophylaxis as well, given all the immunosuppressant therapy. So adding lots of, antivirals and antibiotics, upfront, really to optimize treatment and prevent risk for these patients. All right, so what do we talk about? What do we want to take home, right? So be suspicious of ILD. So if you see these diagnoses, whether it's RA, Sjogren's, systemic sclerosis, or myositis, if they're seeing me or seeing someone else and you're seeing them in the clinic and they're having symptoms or asymptomatic, they probably should get baseline screening regardless. Add on to it smoking, and they probably should be getting these things anyway. With certain diagnoses, right? Myositis, mixed connective tissue, systemic sclerosis, there may be heart involvement. So consider getting EKG or ECG and echocardiogram looking for concomitant heart involvement, and an IVIG may be indicated, especially in a sick patient with an alternative diagnosis. What do you want to look for in an exam? You want to look for and listen for the Raynaud's. Look for arthritis, particularly nothing good happens in the MCPs. So, if the patient has hand pain, just have them hold up their hand. If you can see ridges and valleys between the knuckles, there's not a lot of inflammation there. Or if they have tenderness when you shake their hand, that can suggest MCP involvement. So anything in the MCPs, always abnormal. Take a look at the nails and nail pole capillaries. You're going to see a lot of disease, and keep an eye out for skin hardening. You want to ask about muscle weakness, right? But the CK is not always helpful. When we talk about MDA5 in particular, it's a clinically, unapparent myositis. Patients will have weakness, the CK is normal. So in other clinical scenarios of the interstitial lung disease, rashes and things, that's something where, you will be checking a myositis panel, but the CK may be normal. And then ask about the sicca symptoms. I really think that, Sjogren's is an undiagnosed or limited diagnosis condition because people feel like they're getting older, tired, don't feel well, dry eyes and dry mouth. They attribute to allergies or antihistamines or otherwise. But I think there's a lot of Sjogren's out there. We're just not seeing it. Now, we don't have great treatment, but identifying it may be important, especially with regards to ILD. And then we're always happy to have cases. So talk to myself, your friendly local pulmonologist, bring cases to ILD review meeting. We're happy to see them, happy to give you an assessment, and really take a multidisciplinary look at getting folks better and good treatment. My cell's still the same. You need anything, I'm always happy to call and discuss cases. Happy to try to get folks in that are more urgently ill, but give me a call. We're adding a colleague, so that'll be wonderful. That's all I got.
Well, thank you so
questions.
much. Thank you so much, Dr. Armstrong. This was a whirlwind of good to hear the new terminology and try to get everyone on the same page, and to know that there are therapies out there. The one area that I would start with, and I usually do start with this with nutrition, but the other side of nutrition, which is the microbiome, which is being blamed for all kinds of neurologic disease and all kinds of autoimmune disease, and it got fame probably 15 years ago when the tennis player Venus Williams went vegan after pulling out of the U.S. Open, with Sjogren's syndrome symptoms, and everyone's been sort of thinking that this really is the immune system gone awry based on the microbiome. There was an article published on Sjogren's syndrome just 3 weeks ago in the Frontiers in Nutrition, touting that not only does it have to be a vegan diet, but it has to be a raw vegan diet. Obviously, that's not a randomized trial, but I think obviously we need more data. Can't have these small case series. But are there other things that you would think we could do to improve the microbiome that would help with a lot of the, I mean, trying to avoid the toxicity of the drugs you mentioned? This is, I mean, if we could do something with food or fecal transplant or probiotics, obviously the vegan diet is a prebiotic, but just maybe you could just talk a little bit about that GI axis and how it affects you and your patients' daily lives.
Sure. I mean, I would say public enemy number one is smoking. As a rheumatologist in the South practiced at Wildcat University, used to quiz the interns. He would say, "What are the hospital walls made out of?" And they would say, "I don't know, concrete." And say, "No, tobacco." But I think smoking is culprit number one. The dietary stuff. I think I've read some case reports and others, particularly with ILD, and bad ILD of moving to a plant-based diet and substantial benefit, But I would say there's some cohort skew of folks who want to improve, quit smoking, eat healthier. I think there's a definite component of that that's been proven, when we come into things like MDA5, nothing's going to stop that train. And that's a difficult nature. But I think eating healthier and lower processed foods are all going to be beneficial. The American College of Rheumatology stance on diet currently, our parent organization, they stick with the Mediterranean diet. They have not moved to plant-based recommendations. Some of that may be due to, perhaps, higher protein consumption with the immune system. Don't know, but that's been their consensus statement. They did look at that recently. But I mean, I will always advocate eating healthier and healthier lifestyle. There is some evidence out there, to support the plant-based diet may improve ILD. But you have to have the motivated patient, right? If they're not going to quit smoking, they're not going to move to a plant-based diet. So I think it's a stepwise approach to that, which we're moving there. And we're skewing the system, to the left. We're trying to catch disease earlier, which we are doing, catching disease earlier, treating it earlier, and then moving into the preventative medicine phase where, look, what's causing this and what can we do to prevent it, And I hate to say, I'm doing salvage work right now with, we're seeing folks in a bad way, and could this have prevented 5 or 10 years ago? Sure. But that's been my approach: attack the smoking, work on the lifestyle changes. I think there's some evidence to support plant-based diet. I think there's a lot of stuff where they talk about gut microbiome and changing that and the immune response. I think there's probably a component of that. And if you look at everything, a lot of processed food going around. So, what's added to that, add to the water supply, microcontaminants and, microplastics and everything else, I don't know what's safe anymore, and that's a difficult thing. I think we're realizing that we're putting a lot of stuff in the environment that's not good. And my other concern too is, we're putting a lot of stuff, on plants that's probably not good either. And really, in my wife's hometown in Greenville, Ohio, huge corn and pork industry and super high rate of cancer. And is that all, the fertilizers or the contaminants in the soil? Don't know, but out of proportion to the nation norm. So
Indeed.
we got a lot of work to do on cleaning up our earth and cleaning up our bodies. I agree.
Well said. So Dr. Emmons has a comment and question. Can you comment on the diagnosis and your thoughts about the chronic fibrosing lung disease found in some allogeneic transplant patients with chronic graft versus host disease, usually with Zika? Also, your thoughts about the recent data for CD19-directed CAR-T therapy for systemic sclerosis. Does the response to CD19 targeting and poor response to cyclophosphamide suggest that this is a B cell, not a T cell driven disease? Finally, third question, any data you can share about microbiome variants and exacerbations of fibrosing lung disease, sort of variant of my question?
Yeah. So like the three-pronged attack of systemic sclerosis, the three-part question. I think I got all this. So I can't comment on ILD associated with graft versus host disease. Now, when we look at the systemic or the Sjogren's disease, I'll speak properly, classification criteria, you must rule out graft versus host disease because it will cause similar symptoms. So with Zika, that's graft versus host. That's a classic manifestation of that, along with other diseases, sarcoidosis, HIV, IgG4. There's a host of other things, lymphoma, that need to be ruled out when we look at Sjogren's disease. So If you have someone with sicca, I'm happy to see them, but it could be something else. And if you look at the American College of Rheumatology classification criteria, graft versus host is on there. So I can't speak to the ILD associated with it. That would be more the pulmonologist because it falls out of autoimmune realm. But I would say the sicca is part of that process itself and separate than Sjogren's. Could you do the testing and they could have comorbid diseases? Sure. But screening for Sjogren's, when we look at analysis, it's sicca symptoms. You can prove that with an eye exam and corneal staining, a minor salivary gland lip biopsy through ENT, serologic testing with the Sjogren's syndrome antibody A and B would all be helpful in kind of classifying that. But it sounds like graft versus host. And I don't know about the fibrosing interstitial lung disease associated with that. That'd be more a good question for pulmonology. The second part would be, the B cell component of systemic sclerosis. Don't know, and I think you're getting B and T cell combined. And so this is where I would say, I think we're going to skew spectrum, and really we're doing a staged approaches of what I can get for the interstitial lung disease, what pulmonology can get, but attacking multifaceted autoimmune attack that kind of acts like a vasculitis, a lupus, and then a fibrotic disease. So you're getting all these three things at once, which is why this disease is so devastating. But what's the trouble with that, right? When we do a lot of things and we put people on a lot of immunosuppressant therapy, we're going to hit that 30% rule. We're going to kill them with our therapy. And so this is the difficult nature of this disease, right? And why it's so frustrating. Even with stem cell transplant and Cytoxan, it may not stop it and they may die. And that's a very frustrating thing. Why I would say, a capstone lecture from Virginia Steen, who's the fairy godmother of all things systemic sclerosis from the University of Pittsburgh. I got nothing. She gets up on stage. I have nothing. We have Captopril. We've made a dent in the renal disease. So, well, maybe Actemra, may stabilize things. But she said in her capstone lecture, and she spent her career fighting, systemic sclerosis. I have nothing, and I feel her frustration and pain. It is a horrible disease, and honestly, I have nothing but something that stabilizes it. So, with the B cell, they've looked at Rituxan, may provide some benefit, but then you're just playing this kind of whack-a-mole. You're taking care of the vasculitis component, but then the fibrosis component, otherwise, they're just popping up. And so I think we're going to move towards something better. I just don't know what that is. They've done a lot of study with a CAR T and lupus and seem to provide some benefit. And that's why some lupus patients respond with nephritis to Rituxan, some don't. They're looking at multifaceted approach to the B cells and stopping that damage, which seems to have good success. And Dr. Caxter will speak to that more eloquently than me. But I can tell you, the more you attack the B cell, it seems to make lupus nephritis better. And that explains why some patients respond to Rituxan and some don't. So that gets to the microbiome. I think we kind of addressed that earlier. I don't know. I think there's a lot of research out there to be done, but, if we can do some preventative medicine and they're not in my clinic trying to get, cyclophosphamide or tocilizumab or IVIG, great, but, right now, I'm treading water to keep those patients alive and stop disease progression, get them to quit smoking. So I think there's work to be done, and we're working on that to build more rheumatologists. That's my ultimate goal. But I don't have a good answer, and the ACR at this point in time just supports the Mediterranean diet. But I would tell you, lower processed foods, plant-based diet, if you can tolerate it and afford it, and you're finding organic and not genetically modified, plant material, I think is a good thing.
So I'm glad you mentioned the microplastics. Hopefully everyone will just jot that down and look at March 7th, New England Journal of Medicine. And so Mediterranean diet will come under attack because it is not the same as it used to be before we polluted the oceans. So eating a lot of seafood now seems to be more dangerous than it ever was. All right, well, I really appreciate it. That looks like we've come to the end of time, the end of questions, but we're going to be able to do the Cardinal Minute in just a moment.
And then just for anybody, if there's any additional questions, please feel free to email, text, call. I always have those questions afterwards. I'm happy to field them. Give me a couple days, though, because I usually about 10 or 20, so send them, please.
Just want to thank you again for a marvelous presentation on a lot of stuff that we're going to have to refer to you. Okay.
Yes, sir. Happy to see you.
All right.
Thanks, everybody. And we will be back next week. Dr. Freight, is it Freight's, Dr. Williams? Is that
yes.
Dr. Freight's from Harvard and Mass General will be speaking about lifestyle medicine. We're looking forward to that, definitely. So we'll hope everybody can look forward to everybody joining us again next week. And thank you, Dr. Armstrong, and another great talk. And we really appreciate it. And check outside your door maybe tomorrow or in your office in the ACB. There might be a little gift waiting for you. Or I might leave it with Amanda just to be safe.
All right, fantastic. Thanks
All right,
again.
thanks, everyone. And I'm going to